So, hey everyone, thanks for coming in on this nice fall, chilly Sunday morning. So today, Casey and I are going to be talking about diabetes, and we're also going to be touching on COPD and asthma, and we'll kind of find out why we're talking about those specifically today. But as far as our outline for today, we'll kind of just talk about like, what diabetes is, so like what it is and its etiology, so like what causes it, its epidemiology, so kind of looking at who has it, kind of address some like myths and misconceptions about diabetes because there's a lot of information out there, but sometimes not the most accurate. We're gonna talk about medication, so how it's treated, how it's managed over time, some complications that can occur, and then towards the end of it, I'll talk about asthma and COPD. And to start it off, Casey.
Yep. So diabetes, also known as diabetes mellitus, is the most common form of diabetes. It's a health condition affecting how sugar from food gets into the body's cells. It's extremely common in the United States, with 2/3 of people with diabetes in developed nations live in the United States. And then some of the following statistics are from the CDC. So about 11% of the US population has diabetes, which is about 34.2 million people. And then diabetes is the 7th leading cause of death and the leading cause for kidney failure, lower limb amputation, and adult blindness. So also seen in this chart, the number of US citizens with diabetes has doubled in the last 20 years. The yellow line is the percent of people with diabetes and corresponds to the scale on the left. And then the blue line is the number of people and it corresponds to the scale on the right. You go to the next slide. Diabetes is also a big problem in DC. The percent of population who has diabetes in DC is 8.7%. But like the national rate, that number has been going up over the last few years. And this number is from the CDC, and the chart which shows the increase in percent of people with diabetes is from a website called America's Health Rankings. And we'll have more links at the end of the presentation for people who are interested in wanting to learn more. Next slide. We can also zoom in a little bit more and look at the rates of diabetes in the wards of DC. So this map reports the national average as a bit lower than the CDC, and the rates in DC a bit higher, but it's pretty close. And as you can see, wards 2 and 3 have the lowest rates of diabetes, whereas wards 7 and 8 have the highest rates of diabetes, with ward 8 as over twice the national average. So there's really quite the range in the city. And as we are all aware of, St. Martin's is in ward 5, where diabetes is above the national average. So this is an important community problem for us to address. And this map is actually from a great website called diabetesfree.com. And it has a lot of DC specific resources that can be helpful in learning about diabetes. There's information on like local classes and programs about managing diabetes, and also has information about health insurance and other stuff. So definitely check that out. Next slide. So to understand diabetes, we have to know a bit about glucose and insulin. Glucose is a type of sugar, aka carbohydrate, which makes up a large portion of the food we eat. When we digest food, the glucose is transported in our bloodstream so that it can get to cells that use it as energy. Insulin is a hormone released by the pancreas, which is the yellow organ up to the upper right, actually. And the pancreas releases insulin when glucose levels in the blood are high, such as after a meal. When insulin reaches the cell, it unlocks the cell so that glucose can enter and be used as energy. So insulin would be the key in this analogy. Next slide. So there's a few places where this process can go wrong. And because of this, there's a few different types of diabetes. And we'll start with diabetes mellitus type 1. Next slide. So type 1 diabetes is when there's an issue with insulin production. And this is caused by the body's immune cells killing the cells in the pancreas, which make the insulin. So if we look at the chart, it would be where the X is, and there's there's not enough key to unlock the cells. And this is what people refer to when they talk about juvenile diabetes. And one of the theories of the reasons that why people develop juvenile diabetes is that the reaction is triggered by a virus like a cold or a flu. Yeah, next slide. The other type of diabetes mellitus is type 2 diabetes, which is by far the most prevalent. Type 2 occurs when the cells are resistant to the insulin produced by the pancreas. So if we go back to the diagram here, it's when the lock is messed up and the key doesn't work as well anymore. Next slide. There's the lock messed up. And as a result, all the blood glucose stays in the blood and can cause damage. So the cause of type 2 diabetes is a bit complicated, but obesity and an inactive lifestyle are two big factors. And there's also a genetic component. So if someone in your immediate family or extended family has diabetes, you may be at a greater risk. And there's also a condition called prediabetes, which is when the cells are not completely insulin resistant, but you can think of it as the lock as getting broken. Next slide. And at this point, there will probably be no noticeable change or noticeable damage or symptoms due to the high glucose. But this can progress from prediabetes to diabetes if lifestyle changes aren't made, which Rolando will talk about in a bit. Next slide. There's also diabetes insipidus, which we'll touch on briefly, which is very rare and has to do with signaling molecules other than insulin and glucose. It involves the kidney and our ability to make urine. So there's a picture of some kidneys here. Next slide. And then finally, we have gestational diabetes, which about 2 to 10% of pregnant women develop. Next slide. And pregnant women can develop this because of a variety of hormone changes and weight gain during pregnancy, as well as interactions between the mother and the baby. And what happens is the body cells become resistant to insulin, similar to how we saw in type 2 diabetes. And this process is actually relatively normal during the end stages of pregnancy, but if it occurs too early, then it's harmful, and that's what we call gestational diabetes. And it tends to occur between weeks 24 and 28 and resolves after giving birth. However, it's important to manage it while pregnant for the health of the mother and the baby. And then importantly, about 50% of women who have gestational diabetes while pregnant will go on to develop type 2 diabetes later in their life. So a woman who's had gestational diabetes while pregnant should definitely check in with their doctor as they get older and monitor for type 2 diabetes. And Rolando will take it away from here.
Great, thanks, Casey. So as we learned, that's kind of like the way diabetes kind of manifests itself. And now we kind of touch base on like how it's actually diagnosed. And there's a number of different tests that can you might have heard in passing in different clinics that you've been to. One may be like fasting blood sugar test, oral glucose tolerance test, random glucose test, or a lot of times you might hear your clinician say HbA1c. And really it's this last one, this HbA1c, and I'll just refer to it as A1c. That's kind of the gold standard to actually diagnosing diabetes. And on the right there, you kind of see that the different diagrams and different tests and the different levels that we try to use to like make a definitive diagnosis. And so, for example, that first column there, the A1C test, we can see that, anything normal is your blood glucose being below 5.7%. And as Casey was talking about pre-diabetes, that's like a level of like 5.7 to 6.4%. And then we can accurately say a person has diabetes given that it's above 6.5%. And you can try to like keep this in memory because we'll kind of touch base on this when we talk about some of the medications going forward. But as far as treatment for pre-diabetes, so as Casey said, like this is kind of like the initial stages of diabetes. And so here, one of the biggest things that's usually recommended is lifestyle changes. So, losing weight, having a healthy diet, exercising, so not being so physically inactive, and stopping like smoking cessation, so like stopping smoke habits is a big player in pre-diabetes. And so as far as like nutrition and kind of changing one's diet, a lot of times it might be hard to kind of figure out, well, no, where do I start? There's a lot of information out there on diets. But I think this is a nice infographic from the American Diabetes Association where really, you take this 9-inch plate, like a normal plate, and they recommend that half of it be non-starchy, like vegetables. And then 1/4 of it should be proteins. So like meat, fish, chicken, any like like protein source. And then like the last quarter of it should be a carbohydrate food. And you might be thinking, why, if someone has, is pre-diabetic, they have high glucose, why are they eating carbohydrates? I'll touch that in a little bit in the next couple slides, but really like it's all about balance. And that's really like the name of the game for diabetes and pre-diabetes. It's about keeping balance, about keeping your sugar levels in a level that should, that how it would normally have been if you didn't have diabetes. So that's why I have like the picture of the balanced rocks here. If like lifestyle modification just doesn't work out, and it is very tough, you might have to be put on metformin. And really what metformin does is it actually increases the sensitivity of insulin. So as Casey was mentioning, a lot of times the insulin that's being either you don't have insulin being produced, or the insulin is just not as sensitive as it once was because it's constantly being produced. And so metformin acts to kind of make it kind of a stronger like insulin in a sense, right? And one of the great things about metformin is it doesn't cause hypoglycemia. And so a lot of times when you hear like hyper and hyperglycemia means that your blood sugar is really high, and hypo is when it's like very low. And just like, we have diabetes, we have issues when your blood sugar is high, you can also have some issues when your blood sugar is too low. And so that's one of the great things about the metformin, is that it doesn't cause hypoglycemia. So that low blood sugar, like some other medications that you might be prescribed. As far as like side effects, like any other drug that exists in the world, there are always going to be some side effects. They're for a disease. So, but typically you see like nausea, diarrhea, lactic acidosis, and which might be an issue with like some kidney disease and some heart issues. And then you might see like depleted vitamin B12, which can lead to anemia. So always have an open line of communication with your physician, and always voice these concerns whenever you start any kind of medication. Once we actually transition to diabetes, it kind of changes a little bit. So for like the mild increase of blood sugar, so that's 6.5 to 10%, you're gonna be treated pretty similar to diabetes or pre-diabetes. So again, your doctor's going to recommend lifestyle changes, increasing exercise, or promoting a more healthier diet, and then possibly the metformin. But if your glucose levels kind of remain high, or like regardless of these changes, regardless of metformin, you might have to be put on insulin. And there's a lot of different types of insulin. I kind of put that chart there to kind of show. But really, the initial, when you first get put on insulin, normally it's going to be a long-acting insulin. And actually, like the main goal here with insulin is to keep your fasting glucose between 70 to 100. And I just want to like kind of clear up some confusion, because you see like the percentage versus the 70 to 100. So the percents are always going to be based off of that A1C, like the actual, when they draw your blood in the hospital or the clinic, versus the glucose, fasting glucose. That's actually that little device, that glucose monitor that you see like in CVS, and that your doctor will have you use to kind of monitor your glucose throughout the day. And so really, it's about keeping your fasting glucose between that 70 and 100. And if the long-acting insulin doesn't work initially, like if it's still too high over some time, you might get put on short-acting insulin in addition to the long-acting insulin. And you might have family members that might be like, might have this kind of scheme kind of play out over time. And it's known as the basal bolus scheme. And really what it is you kind of start off to the left where like the sun is at. You have in the morning, you wake up, you check your fasting blood glucose, you do the skin prick test, and you take the short acting insulin, which is that kind of gray syringe. And then you eat breakfast. And then in the lunch, you do the same exact thing. You check your glucose, you take the insulin and you eat your lunch. Dinner, same thing, check your glucose, take the short acting insulin, eat dinner. But then what changes is at night, you'll check your glucose. Obviously there's no food, right? Because you're gonna go to sleep. And you'll take this long acting insulin to kind of get you through the day, through the night. And the reason why this is kind of done is because it mimics what your pancreas normally would do in a non-diabetic, condition. And so this kind of just mimics the way, like the levels of insulin that's being produced by your pancreas over the day. We're just doing this like medically. And so for diabetes, the actual treatment, like there's a lot of options out there. There's a lot of combinations that they may exist depending on if you have other like conditions besides diabetes. So, I mean, really the thing we want to say is don't be afraid to talk to your doctor and, seek information when you can, because, that's what your physicians are there for you to answer your questions and making sure that you are fully informed about any decision that you decide to take. And then also, talk to your doctor about how to properly use insulin and medications, because like I said, there's a lot of things out there. So you always want to make sure that you're doing everything as best as you can. So these are kind of some myths that the American Diabetes Association kind of puts on their website, because a lot of times, we have a lot of diabetes in communities, and word gets around the barbecue, and you're just try to figure. You hear all kinds of things, and so that's why we kind of put some quotes here and kind of address a lot of it. So one was being overweight will always lead to type 2 diabetes, and like Casey said, it's a major risk factor, but it's not 100% causal. But again, you always want to try to maintain a healthy weight and be as healthy as you possibly can. If you're diabetic, you cannot eat fruit, but you can eat a lot of potatoes. So, and actually kind of tied with that one is that third bullet is all carbs are bad. And, it's not so, I mean, it is an issue, right? Because, certain foods are very rich in carbohydrates, very rich in sugar. But again, kind of with that slide with the rocks, right? It's all about balance. It's not that you can't eat any of it. It's that you need to be aware of how much you can eat, and in order for you to be healthy. If your doctor says you need to start using insulin, it's because you didn't take care of yourself. That's not the case. A lot of times, with these lifestyle modifications, it kind of just progresses on its own. So it's never your fault. If you're truly adhering to the advice of your physician, sometimes these diseases just kind of continue to progress, and you have to use medications to help manage them. So don't ever feel like it's your fault in any way. I should eat less than normal or lose weight to manage my diabetes. So with this, they're trying to get at the fact that you might stop eating completely or skip meals, which again, it's not about skipping meals. It's about eating the right kind of meals so that your sugar is nice and balanced. Metformin will decrease my blood sugar and make me sick. So like I kind of said, one of the benefits of metformin is it's actually doesn't cause that. That's the reason why a lot of folks might prescribe it, is because it doesn't reduce your blood sugar to dangerous levels. As far as complications, so really just this persistently high amount of sugar in your blood, right? This blood glucose can kind of destroy some of the vasculature. So you kind of have your arteries and veins in these small little vessels called arterioles, and there's even smaller ones called capillaries, but they're the ones that kind of take the blood to all your tissues, your organs, like your eyes and everything. And so if those start to get damaged, the organs that they send blood to will also start to be affected. And so for the eyes specifically, you might get retinopathy, so you'll see blindness in some diabetic patients. For kidneys, you'll start seeing diabetic nephropathy, and I'll talk about that in the next slide a little bit more. And then for the nerves, you might actually start getting some nerve damage from like this, very high amounts of glucose in your blood. So you start to lose sensation in your fingers and your toes. Some of like your normal like bodily functions might be dysregulated. So you might have like diarrhea, pass gas, and then kind of this mixture of blood supply being affected and nerve damage is what often leads to foot ulcers. And so a lot of times diabetics might actually have like a damaged foot and not even realize it because of the nerve damage. And, it could progress and get infected, and surgical amputation might be called for at that point. As far as diabetic nephropathy, essentially what your kidneys do is I actually have this video, but it's, how much time do we have? It's kind of long. I'll just skip this. We have other videos too. But essentially what your kidneys do is they're like the filters of your body. Like all the blood passes through these two filters, and they clean your blood, and they kind of allow this perfect balance of hormones and electrolytes and everything that kind of like maintains your bodily functions is done by the kidneys. And like we said, when we have this high glucose, it starts to actually affect these kidneys, and you start to have like this dysregulation. And you start to see symptoms of like, swelling of your feet and your hands and your eyes. You start having like shortness of breath, so like you have difficulty breathing, fatigue. You start to feel very tired. You have to, frequently urinate. And then you start having like blood pressure issues. It could be like high blood pressure, low blood pressure. Because really, like, again, your kidneys are just like the perfect filter for our blood in our body. So now we're going to transition a little bit more into asthma and COPD. And Dr. Kasaraneni, she wanted us to talk about it because when we think of DC, when we think of the wards, we often kind of think that, everything is like in equity, right? We think of everything that's, being equal. And so like this map, they found that in DC, the prevalence, right? So like the amount of people that have asthma is 10.6%. And that's, kind of high, given that the national average in 2019 was 8% for adults and 7% for children. And so, overall, in Washington, it's pretty high. But when we break it down by wards, we actually see that's not, what the picture really was. It's not, it's kind of an interesting take, where we see like in like the, wards, 7 and 8, we see like that it's red, right? This 10.6%. But actually, when you look at the data provided by DC Health Matters, they actually show that like Ward 8, for example, has a prevalence of 23.6%. So that means like 1/5 of the population has asthma in Ward 8. And you compare it again to the national average of 8%, it's pretty astonishing. And so, what is asthma? And in the crux of it all is asthma is just kind of this allergic reaction that occurs in your lungs. And this increased allergic reaction to something that normally shouldn't be too impactful, kind of just like shoots off the charts. And to the right there, you kind of see what happens over time is you have this allergen that's irritating your lungs. And then you see that thickened airway space on that far right image. And that's what kind of gives you that difficulty to breathe. Because you can actually are able to breathe in, okay, but you just can't breathe out. And that's why asthma is also known as like an obstructive lung disease, because you just can't get that air out of your lungs, and it's just not a great thing to have. And here we want to look at like what triggers it. So asthma can have all kinds of triggers. So it can be like a respiratory infection. It can be just cold, like being exposed to cold air, stress. Obesity is a risk factor for it. Dust, pet dander, drugs, household chemicals, physical exercise. There's such a thing as exercise-induced asthma. Smoking is a big trigger for it. Pollen, diet, all kinds of things can actually trigger an asthmatic attack. And so one thing that Dr. Kasaraneni wanted us to kind of talk about is like, with 23% of the residents in Ward 8, having asthma, and in DC in general, being pretty high, how to actually use an inhaler. And so I have a video here, and actually I realized I didn't share it correctly, so I have to like share. Let me stop sharing real quick so I can share with sound, and that way the video. Okay, great. So this is how you.
There's something in Washington called the Reconciliation Bill.
Not
Just,
many Americans understand exactly.
Here we go. So this is how you do not use an inhaler. Anyway, can everyone see my screen first of all?
Yes.
Yeah, okay.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you have to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Jerk.
Yeah, so that's how you don't use an inhaler. And then let's see how we actually do use an inhaler. So can you guys see the screen, the new video?
Yes.
So this is how we actually use it.
Using a metered dose inhaler. Take off the inhaler cap and make sure the mouthpiece and spray hole are clean. Shake the inhaler 10 to 15 times. Without the inhaler, take a breath and breathe out all the way. Hold the inhaler upright. Put the inhaler in your mouth, above your tongue, and between your teeth. Seal your lips around the inhaler. Begin to breathe in slowly. Press down on the inhaler one time and keep breathing in. Hold your breath for 5 to 10 seconds. Open your mouth and breathe out slowly.
Yep. So that's how you should properly be using the inhaler. Let's see. Okay. So COPD. So this is another obstructive lung disease, very different from asthma, but also with the similarities. And here again, looking at DC in the wards, like the national average for COPD in the US, I think back in 2018, was around 6%. And here we see like, certain areas like the northern region is, much less than 6%. But then again, we look at some of the, wards, 7 and 8, towards the east, we see like increasing prevalence and like they go up to like 10%. And so that's why, again, we think this is kind of like a big issue here in DCs. And that's why we want to talk a little bit more about it. And so really what is COPD? It stands for chronic obstructive pulmonary disease. And it's really the manifestation of two diseases, specifically chronic bronchitis and emphysema. And they're both a little bit different. Chronic bronchitis is more so kind of similar to asthma in the sense that you do have like this increased inflammation and excess mucus production. But then emphysema is kind of like, if you think of our lung as a balloon, you think of a balloon that's just been like stretched out, and you try to breathe into that stretched out balloon, it's just not going to inflate very well, right? And so that's kind of what emphysema is. And both these conditions are kind of allow you for this like difficulty to breathe. And like the biggest risk factor for both of these conditions is actually smoking. And you might think, well, smoking, why is that such a terrible thing? You can kind of see from that image in the bottom left there that these are all the different chemicals that are measured and found in smoking, right? So like there's nicotine that are found in insecticides. There's ammonia that's found in toilet cleaner. There's methanol that's used for rocket fuel. You have methane, which is like sewer gas. Like all these different kind of chemicals found in these very damaging, places or products. That's what folks are smoking when they're smoking cigarettes. But smoking is the biggest one, but there is also like air pollution. There is a genetic component to it as well, right? So if you have family members that have COPD, your risk of getting it is also increased. And a lot of times, what the way it manifests is you'll see like a chronic cough, a production of mucus specifically for the chronic bronchitis. You feel very tired, right? Just because you're not able to breathe as you normally would. The shortness of breath. And you'll have like chest discomfort. You might start having chest pain over time. And so I kind of want to ask the question to the group. What % of COPD cases are due to smoking? Like, you can just throw it in the chat. Like, take a guess in the dark, I guess. Let's see, look in the chat. D, 55%. It's pretty high. But what if I told you it was actually E? 90% of cases are due to smoking. So again, just wanted to kind of reemphasize just the fact that smoking, just when you ever hear those, infomercials while you're driving home from work, like, oh, you should quit smoking. This is usually why, because it kind of manifests in really ugly ways. So as far as treatment, the biggest thing you can do if you have COPD is, stop smoking. You also might need to use bronchodilators, so like the inhalers to kind of help you with your breathing difficulty. Staying up to date with important vaccinations. So this was kind of interesting because if you have like some kind of respiratory infection, like you get the flu or something, that actually can, make your COPD worse. So you want to make sure that you're vaccinated, staying up to date to everything so that you don't get sick and make your COPD more aggressive. There's combinational therapy, there's anti-inflammatory therapies to kind of like help with the inflammation, because that's really what it is, especially with that chronic bronchitis, like increased inflammation in your lungs over time. And then there also might be put on antibiotics, oxygen therapy, or surgery if it gets really, really bad. And I think that wraps up our presentation, and we're ready for any questions that you guys may have.
Thank you so much. This is Charlene. I have someone in here with me, my sister Linda, and she does have a question.
Okay, what is the impact of secondhand smoke? Is it still 90% of the COPD cases, or do you have that percentage?
I don't have that percentage, but I can follow up in the email that David sends around with that percentage. Yeah, unless one of the physicians on the line may know on the top of their head, but yeah, I don't have that exact figure in front of me.
It's actually pretty high in terms of secondhand smoke. That's why we emphasize that, and especially for children, we emphasize that you minimize the amount of smoking or stop smoking. That's good. That's a good emphasis, stop smoking, actually. Because some folks will say, well, I only smoke outside, and when I come back inside, I never smoke in the house. But it has been shown that obviously you're bringing that smoke and all of the things that were just mentioned in terms of what's in the smoke and chemicals do linger into the clothes and linger onto the body. So that's not a way of kind of avoiding the secondhand smoke exposure by just smoking outside. So it is important that if you are a smoker, especially for small children, it increases the risk for infections, ear infections, throat infections, et cetera, that you stop smoking. And certainly for adults, it's important to stop smoking. It's probably over 50% in terms of the impact. So it's much higher than we think.
Okay, and then another question. Are we talking just about cigarette smoking? How about cigars and the marijuana that smells like skunk now? All even the vapor. Are we talking about just cigarettes, or are you talking about all smoking?
Yeah, I'll let Rolando, if he wants to address that, and then I'll popcorn in to answer the question as well.
Yeah, so I mean, I would imagine, yes, it's all forms of smoke. Because when we think about our lungs. We think of like just kind of like we look at our own bodies. We have our skin. We have everything that's kind of protecting the inside, right? Our organs. And so anything that we breathe in from the outside inward, it's like a delicate environment within us. And so the reason why I think smoking is such a big factor is not only the chemicals that's in it, but the fact that it's an irritant. And regardless of, if you're cooking with wood or if you are smoking a cigarette, with the cigarette, you do have the chemicals as well, but you're introducing that irritant into your lungs that normally shouldn't be there. And you're causing that inflammation, and that's what's causing you to have the chronic bronchitis or the emphysema over time. So I don't know like exactly like if I were to put it into like a list of like which one's absolute worst and which is like the least worst, but I think all forms of smoking are pretty terrible, honestly.
So Rolando hit it on the head. All forms of smoking, whether it's cigar smoking, whether it's cannabis or weed, each actually have a differential impact. It's interesting, just as a caveat, there's certain groups of individuals who actually smoke cigars more than cigarettes. I work at the police and fire clinic, and when I say, do you smoke? Many of the individuals will say, no, I don't smoke. But if I say, do you smoke cigars? There's a significant percentage of them that do. So for some reason, smoking may have a certain status associated with it in terms of cigar smoking, and many of them do. And there is a significant increased risk as it relates to lung injury, lung damage, lung cancer associated with cigar smoking. There is an increased number of studies that are looking at cannabis. And we do know that there is, again, depending on the preparation for the cannabis in terms of smoking, as to its impact. Now, of course, you can get weed that has sort of a what I call a sickly sweet smell to it, but you can get weed that's smoked and it sort of has a way to hide that that particular odor. But any kind of inhalant, as Rolando said, that you're putting directly into the lungs is going to have an impact on those small little air sacs and on the big bronchial tubes. And so you can't sort of minimize or get away from the inhalant effects by doing other types of smoking. Don't forget about e-cigarettes, of course, and vaping. That is significant, particularly in our youth. And we should be really advocating in a strong way against the use of those other means of smoking as well.
Say it again.
So Angel has several questions in the chat. Her first one was, why do wards 5, 7, and 8 have such high rates of diabetes? And I would piggyback on top of that. You also showed geographic differences in the asthma and the COPD. Are there explanations for these differences? Are there smoking rate differences between the areas? Do they think it's environmental differences? Do they really, or is it just sort of this is measurement of what it is, and they're still trying to tease out for the diabetes, asthma, and COPD?
Yeah, no, it's a really great question. And I think the way it plays out is there's this term that gets used a lot in public health called the social determinants of health. And what it means is that your zip code dictates more of your health than your genetic code, right? And so if you live in an environment where let's say there's not a whole lot of like fresh foods around you, like fresh vegetables, fresh fruits, kind of like healthier food options at a reasonable price, you're going to be less inclined, especially if you live, if you work multiple jobs, just trying to pay the rent, it's going to be tied into each other. So that's why they say like a lot of times areas of high poverty typically tend to have the most health conditions because these health conditions are just tied into everything that is tied in with poverty, right? So when we think of like wards 5, 7, and 8, there's a lot of folks that are struggling financially, especially right now after the pandemic. and they're trying to figure out where the next meal is going to come from. They try to find the cheapest foods, and a lot of times, unfortunately, it's like the cheapest foods may not be the healthiest. And there's certainly ways around that, with like budgeting and stuff. But specifically for the diabetes, you're more inclined to maybe see more fast food restaurants than you are to see a farmer's market or like fresh vegetables for sale, right? And so that kind of ties in with the diabetes aspect of it. And then as far as the asthma, again, there are like certain, like, so it kind of shows like the different like pests can possibly cause some asthmatic symptoms, pollution, like you said. So all these things kind of tie into, unfortunately, where people live, they're going to be exposed to high pollution if they're like in the poverty-stricken community, and they're not going to have so many dietary options. And so there's a lot of setbacks, unfortunately, in these communities. And so that's really where we see the manifestation. And it's kind of this whole idea of like health equity versus like health disparities. I don't know if you've ever heard those terms, but really it's like health equity is like the structure, right? The fact that there are no grocery stores around me that I can buy fresh veggies, but there's like 20 McDonald's nearby. That's the health equity part that manifests into the health disparity, is that, well, now my community, we have high rates of diabetes because of that.
I'd like to add on to that a little bit. The concept that Rolando's like talking about with the lack of access to healthy food is called like a food desert. And it's been researched like quite a bit, especially in DC. So those ward areas have a higher prevalence of food deserts. So if you want to look up stuff later, that's a good term to look into.
I would say, piggybacking on that, Ward 7 and 8 only has one grocery store compared to the other wards. In addition, most recently, folks have said, well, now we have two because we have an organic store. But you have to think of prices and access to fresh vegetables, fruits, and all of the nutritious foods that we need. It is much higher in terms of cost. So really, in terms of choice, you don't have a lot of choice in terms of Ward 7 and 8. And so that has a direct impact on what Rolando showed earlier in terms of that plate that divides up the different proportions of food. So we as physicians and medical students need to be sensitive to that as it relates to where people live, where our patients live, because it may be easier to state that for diabetes, lifestyle changes are critical, but if you're limited in terms of your choices, then that becomes hard. The other piece has to do with exercise, body movement. If you're living in an area where you don't feel very secure in terms of being able to go out and to be active, and just the aesthetics of where you live may not be very positive. There's not a lot of trees, the parks and recreations may be limited. Then that also may be a deterrent for you wanting to get out and to be active and exercise. And we don't always want to just have exercise equipment in our home and make that be our only form of activity. So when we talk about lifestyle, it is the full scope of our life that is preventative in terms of diabetes as well as asthma and COPD. And let's not forget stress. Just our own personal stress in terms of our lives can make a difference and can also be an impact in terms of a risk factor for these, what I would call chronic lifestyle conditions. And if we're not managing and not able to manage our stress because of what was mentioned earlier, then that can have a significant impact on our choices as well.
So another question from the chat comes from Angel. Where is the pancreas in your body? Under the stomach? Question mark. What is that purple tube, and what does the pancreas do again?
Yeah, I can take this one. Yeah, that's correct. It is located under your stomach. So like right when your ribs end into your abdomen, deep in there, that's where the pancreas is. And it has two functions. The main one that we talked about for diabetes today is that it produces insulin so that your cells can take in glucose for energy. And then the other function it has is more of a digestive function. So it provides molecules that break down food as it goes into your small intestine after the stomach, which was what the purple tube was. So that's the beginning of your small intestine.
And then another one from Angel. What can gestational diabetes be treated with drugs? And if and how do the drugs impact the baby?
Yeah, I might have to defer to the doctors on the line for this one, but I do know, and I don't know if I mentioned this in the presentation, that gestational diabetes does most of the time resolve after the mother has given birth. So I would expect that treatment would try and be a little bit more conservative, especially when you're considering the health of the baby as well. But I think that's the extent to what I know on the topic.
So we tend to be more aggressive with treating diabetes because of its impact on the baby. With diabetes, there are complications that can extend to the baby, especially in terms of weight at delivery. If diabetes is not managed very well during pregnancy, then that impacts the birth weight of the baby, and that can be a problem very early in terms of the early development of the child. So we tend to be very much more aggressive. Our parameters in terms of keeping things within a normal range are a little bit different than when we're not pregnant. And insulin is used fairly often during diabetes. And then, of course, as was mentioned, things tend to normalize afterwards, although it may not be immediately afterwards. But yet, yes, insulin is usually the predominant medication that's used because of its safety profile in terms of pregnancy, and because of the fact that we can have better control of glucose with management of insulin. And as you can see, there's different insulin derivatives that can be used, ultra short acting, long acting, so that we have better management control of diabetes throughout pregnancy.
Okay, another question then. Why does gestational diabetes cause big babies? I mean, how does that affect their birth weight? Why is that affecting the baby's birth weight?
I can take that if the students don't want to charge in. I'll give them a chance if they want.
I think it's been a little bit since we reviewed this in our classes, so you can go for it for sure.
It has to do with the influence of the glucose on the baby. That sugar that goes from mom to baby, because baby does not have the same mechanisms with which to control and metabolize glucose, that glucose is affecting baby's development in utero and size. And so for that reason, the baby will have a detrimental effect if the sugar is not corrected in mom to have a larger size during development in utero as well as afterwards. So that's why we have to really have tight control for mom, so that then we differentially will have better control for baby.
So does the baby then have diabetes?
Actually, the baby can develop diabetes. That is correct. And we want to prevent that from happening. So by having strict management while mom is going through her pregnancy, then we then prevent that from occurring in baby. And when the baby's born, there's a lot of activity around checking the sugars to see what those sugar levels are in the baby, and sometimes having to intervene during those first early days of life to prevent the sugars from having an influential effect on the baby.
Okay, is that the cause of juvenile diabetes then?
No, because as I said, if you have very strict control over diabetes in mom, that is not going to differentially then cause diabetes in the baby. I think, I'm not sure if it was Casey who had talked or Rolando who had talked a little bit about the actual causes of juvenile diabetes, and that has a more genetic influence, and it's a more complex interaction than simply the mom having diabetes and the baby therefore being influenced by diabetes during that pregnancy period. It's a real different sort of complex mechanism that I think Casey may have talked about a little bit earlier.
Okay, I might have missed that, so thank you.
Yeah. That might be a good opportunity for Casey to review that if he wants.
Yeah, sure. I don't know if Rolando, could you pull up the chart again for that that section? Could you go to the juvenile diabetes page? So yeah, type 1. Yeah, so as you can see in the chart here, we have the pancreas, the yellow thing, and there's the the beginning of the small intestine. And so for juvenile diabetes, you're having a problem producing the insulin that would go to the cells to unlock the cells to allow glucose to come in. And the causes of this can be more complicated. Genetics is definitely a factor. And usually physicians see the onset of juvenile diabetes when after a virus such as the flu or a cold. And that's not to say that the flu or the cold is causing the diabetes. It's just that because of this additional stress on the immune system, something happens that doesn't allow the pancreas to produce enough insulin for the body.
So I think that was good.
You're off now. Okay, you can say this.
So the another one from Angel is if you live in an apartment and smoke/weed vapors get into your apartment via air conditioning, vents, stairwells, and whatnot, can you have breathing problems caused by that secondhand type smoke? And I guess implied in that, is there anything that you can do about that?
Yeah, so kind of going back to Dr. Bullock was saying is that any kind of secondhand smoke is damaging. And so if you are living in a building where you're kind of constantly exposed to these kinds of things, yeah, you absolutely could manifest some breathing difficulties. And for the second part, how to stop that, I'm not not 100% sure, but maybe talking with your landlord, looking at some zoning like ordinances, or even talking with the public health office of the county to see if they have any recommendations for maybe air filters or seeing action that way. They're providing air filters for community residents. I don't know if any of the physicians kind of have some experience with this.
Yeah, so this is a great plug for physicians to serve as advocates for their patients. And when we see our patients in the office and we talk to them about their homes and their environments, this is part of sort of the social aspects of the history. We can get an idea of what is happening at home, and some of the comments that were just made earlier in terms of the secondhand smoke that you can smell through your vents, or heavy smoke, or even cannabis use in the apartment, or that you can smell in the stairwells, et cetera. Having your physician basically advocate with the landlord, with the owners, in reference to the fact that you have a patient who has asthma or COPD, and therefore is experiencing symptoms or is having exacerbations or these periods of time where their asthma or their bronchial infection gets worse. And therefore the landlord has a certain responsibility to make sure that the environment is safe And this is part of that definition of safety in the environment. So that the physician can be very helpful in writing letters actually to the landlord or to the owners of the property and informing them of what they need to do. And that's not an uncommon problem. We do see that particularly with children, where there seems to be a little bit more advocacy than there is in adults. So I'm glad you asked that question in the sense that we as physicians need to be more in tune in asking the questions, as well as more aggressive in terms of responding to what's happening with our patients in their homes and in their environment by reaching out to the owners of the property, the landlords, the managers of the apartments, and sometimes taking it to the next level, as was mentioned in terms of Department of Health officials.
So then this is sort of a group of questions from Angel. How much does a glucose monitor cost and/or COPD breathing machine? Does Medicare, Medicaid cover cost of any of these things? If so, how to not have out-of-pocket expenses? Both Medicare and Medicaid cover out-of-pocket blood glucose monitors. You'll need a prescription from your healthcare provider. And is there ways to get discounted rates for insulin? I heard it was very expensive. Also, what's the difference between having insulin shot like you have with the EpiPen versus any of these new patches I've seen on the TV to add insulin? So it's sort of like the cost of this infrastructure to deal with diabetes and how can you pay for this?
Yeah, I think Charlene was contributing, and I will defer to her, but her answer is correct in terms of she's more the expert here and closer to the situation. But yes, her answer is correct, but I'm going to let her more eloquently speak about this.
Okay, thank you, Kim. If health insurance obviously is a big issue, but in DC, we did expand Medicaid when it was first made available under the Affordable Care Act back in 2010, I do believe. So if you have insurance coverage under Medicaid, and interestingly enough, 1 out of 4 residents in DC are covered by either Medicaid or the Alliance program, which is sort of like a Medicaid look-alike program for folks who do not qualify because of for Medicaid, because of the federal program means that you have to have basically legal status or be a citizen of the United States. If you don't have that status, DC has set up a program called the Healthcare Safety Alliance. So you probably will hear it referred to as the Alliance program. And a lot of its benefits kind of mimic what folks who qualify for Medicaid receive. Having said that, Medicaid does cover the cost of blood glucose monitors, and also it covers the cost of spacers. That's one thing I didn't quite hear when we were talking about asthma. The use of a spacer with the inhaler can drastically increase the effectiveness of the inhaler, because it kind of helps people get control of their breath. And a lot of the spacers are breath actuated. So when taking that inhalation, that breathing in, having the use of putting the inhaler inside this, connected to the spacer and then doing that, if you're kind of clumsy or not really coordinated, it's really, really helpful. And Medicaid will pay for, and Alliance will pay for the cost of the spacer. There are basically no out-of-pocket costs under Medicaid, so it's like 0 co-pays. Medicare, in some cases, it may be a 20% co-payment for the Medicare beneficiary, but if that beneficiary also qualifies for Medicaid, then Medicaid would take care of that 20%. There are also instances many times where drug manufacturers and device manufacturers have patient assistance programs. So if there is a case where someone just truly can't afford it, most manufacturers will provide them with a free blood glucose, monitor, especially that, because actually the cost of the monitor is really not the biggest issue. The issue comes with the cost of the test strips when you're using the glucose monitors. Medicaid and Medicare also cover the cost of the test strips. Okay. I don't know if that's Angel, is that?
I think there was one last thing about the cost of insulin itself.
Insulin. Well, Medicaid covers the cost of insulin, as it's written on a prescription. Again, there should be no out-of-pocket costs. I know that for Medicare, there's like a whole array of different programs under Medicare. And there's a Medicare Part D, as in David, which is the prescription drug program under Medicare. Most of them will cover the cost of insulin. Some of them may have a formulary where they may prefer one type of insulin over another, but usually working between the insurance company and the prescriber, you can come up with the right choice for that particular patient. Medicare may have a nominal cost. It can range anywhere from no cost, $1.10, $3.30. That's for folks who were eligible for both Medicaid and Medicare. If you're just eligible for Medicare only, you can kind of select a plan that might meet your needs, and those out-of-pocket costs may be a little bit higher, but still usually in the under $10 range. And again, if there's a person that's having a really big problem with affording the medications, the manufacturers of the insulin do provide patient assistance programs where there's no charge for obtaining insulin.
I can just piggyback on Charlene and state that as physicians, again, we should be aware of these differentials and these supports for our patients. And if we are not fully versed, social services can come alongside us, especially in the Medicaid program. There are social supports that can help and guide patients in terms of, or individuals in terms of making these decisions and choices, and especially as it relates to the different formulations for insulin as well. So I just want to put a plug in there for our social service colleagues and how they can really be extremely beneficial. We're not going to know all of these details and be adept as Charlene is. And so that's why it's important to have social services. I also want to underscore what Charlene mentioned about the spacers. Really, really important for kids because they're not going to have that coordination as was mentioned. And so the spacers become very, very important for children. And it's very, very important for our older patients, older adults as well, where the coordination maybe play, and even for younger folks as well. So I think all of us could benefit from just remembering the spacers and the fact that they are covered. I just want to quickly say that there was a question about Glucerna, and I know we're maybe running over time. So for Glucerna, yes, there is a place for Glucerna. It is utilizing a different carbohydrate type product. It's a low glycemic carbohydrate, which does lead to better control of glucose. That's sort of the underlying premise for all of these. I'm not wedded to any of them, and there is a booming market for this. So I would really be cautious in terms of saying that they're the be all and end all. And it is something that you do want to talk with your physician about relative to your particular condition before you just simply state that, Glucerna is the way to go, or some of these others, even the sugar substitutes as well. That's another whole different discussion. So.
Thank you for catching that missed question. And I think that's all the questions that we have for today. Do we want to do a short plug for the next talk, and then afterwards maybe have a closing remark, and then we'll stop the recording? Does anyone know what the next talk and when it's going to be?
I know when it's going to be. I don't know what the topic is. It would be on Sunday, November the 14th is our next scheduled talk. I'm not sure. By process of elimination, I can imagine who's going to be giving the talk because everybody else has done it, but you all may want to speak up if you know what your topic is. You would like to share it at this time.
Yes, good morning, everyone. I believe in 2 weeks, it's going to be me and Christian talking about sort of mental health around the holidays and sort of handling just sort of the stresses, both the exciting parts and the stresses of the holidays, and just sort of getting ready for all of that. So I'm looking forward to it.
Great. I'm looking forward to that too. It'll be very, very timely. Okay.
And do we want to do a closing for today's topic, Rolando or Casey?
Sure, I can throw in a few words. As we've already heard, your situation is going to be unique if you're struggling with diabetes or asthma or COPD. So definitely talk to your doctor about your case specifically. We've laid out kind of the general principles here, but I think the most important thing is establishing that communication with whoever your provider is.
Yeah, and just kind of bounce off that, we hope that this presentation just kind of like, it's that initial stepping stone to kind of just knowing a little bit more information about these diseases and like the people that you love around you, and definitely use it to find more resources, and don't ever be afraid to talk to your physicians, because that's what they're there for, is to help you.